Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about bowel obstructions. Now, from a surgical perspective, bowel obstructions are a very, very important cause of the acute abdomen, and it's one topic that's very, very commonly assessed on examinations. And the key premise of a lot of those questions is going to be being able to distinguish the different types, the different causes of bowel obstructions, and then devising a management plan. So that's what we're going to focus on today. And I mentioned an acute abdomen. So let's talk a bit about what is an acute abdomen and why is it important. So acute abdomen just refers to severe abdominal pain, right? And many of the causes are medical as well as surgical emergencies. And these include things like acute peptic ulcers, pancreatitis, bowel obstructions and ruptures. And then also you always have to think about non-GI causes. So ovarian torsion, ectopic pregnancies, ruptured AAAs, and so on. Now, when we say that a bowel is obstructed, this can take a few forms. Firstly, you can have something that's purely stuck in the lumen, and that's creating a physical blockage. You can have an issue with the actual bowel itself, where it's stuck to something externally, causing kind of a sharp bend, and that bend prevents the flow of fecal matter. And then thirdly, you can have a situation where the bowel kind of loops on itself, entangles, and then that obviously causes an obstruction. Now, you need to know the typical features of a bowel obstruction, and these are the cardinal signs of a bowel obstruction. So please remember these. We have abdominal pain, and that fits in with our acute abdomen, vomiting, constipation, abdominal distension, and decreased or absent bowel sounds. Now, I'll go through all of these and talk a bit about small bowel obstructions and large bowel obstructions and how the two differ in terms of how they present. I'm sure you know that obviously they affect different things, but when you have a patient in front of you, you should be able to make that distinction. Now, the severity often depends on the degree of obstruction. So is this a total obstruction or a partial obstruction? Is there a rupture, and is there any vascular compromise? And the few things then when you see in a patient should always make you panic a bit are firstly absent bowel sounds, because that means that the bowel is completely dynamic, and that's really bad. Hemodynamic instability can be because of two things. You can either have vascular compromise leading to hemodynamic instability, which means that your gut is turning ischemic, or you could have a perforation, and perforation can lead to peritonism, guarding, and hemodynamic instability. And then you can also have a septic patient, because as you can imagine, the fecal matter is obviously full of multimicrobial matter, and you don't want that leaking into your bloodstream. So I talked about small and large bowel obstructions. So let's talk about each one of those in a bit more depth. So SBOs are the more common of the two. So most bowel obstructions tend to be SBOs. And this can obviously be an obstruction of the duodenum, the jejunum, or the ileum. The two most important causes of an SBO that you need to know are firstly adhesions, and this is often due to past abdominal surgery. So always ask, have they ever had surgery to their abdomen? Common things that people might have had that's now presenting with an SBO. So always ask about things like, have you had your appendix out, your gallbladder out? Have you ever, for females, undergone things like explorative laparoscopic procedures, hysterectomies, cancer resections, and so on? And then you can also have an incarcerated hernia. Typically, an indirect inguinal hernia that has become incarcerated can lead to an SBO. Now, we briefly talked about the cardinal signs of bowel obstruction, but going back to how an SBO presents specifically. So SBOs are more likely to present with vomiting. Now, if you think about it, in your entire chain of bowel from the duodenum to the rectum, the earlier or the higher up the obstruction is, the more likely it's going to present with vomiting, right? Does that kind of make sense? Because if the obstruction is kind of at the very end in the rectum, it's going to take a lot of time for all of that fecal matter to back up, and then obviously for it to cause vomiting. And vomiting with SBOs can either be bilious or non-bilious, depending on the site of obstruction. Now, what does this mean? Well, we know that bile drains into the second part of the duodenum through the ampulla of Vater, right? And that's the common bile duct joining with the pancreatic duct that drains into this ampulla. If you have an obstruction before this ampulla, any bowel or any regurgitated food or fecal matter is not going to have bile in it, right? And therefore, it's going to be non-bilious. However, any obstruction after this point is going to lead to that bile also regurgitating up your duodenal stomach and then you throwing that up. So that's a good point to know. SBOs typically present with less distension. So the premise of distension is when you have a blockage here, proximal bowel or the bowel just before that obstruction is going to dilate, right? And although small bowel can dilate, it's not going to dilate as much as a large bowel obstruction. It often has a faster onset. When I say faster onset, I mean faster onset of symptoms, and that goes back to where the obstruction is. The higher up, the earlier it's likely to present. And then as we talked about vomiting and kind of stuff coming up from the mouth side of things being faster with SBOs, stuff coming out the other end is going to be slower. Same exact principle that if you have an issue with the GI tract, the closeness to the site is going to determine how fast the onset is. So because the small bowel is very far away from the rectum, constipation and bowel changes are going to be a late sign with SBOs, but an early sign with LBOs. Let's talk about LBOs. The leading causes of a large bowel obstruction are firstly colorectal cancer, and any patient who comes in with an LBO should usually undergo a thorough check for colorectal cancer. This obviously would not be done at that exact point in time. You would do imaging for this patient and look if you see any masses, but even if you don't, all the patients, once you treat them, should undergo a colonoscopy. You can also have a volvulus and intussusception. Now, again, let's just go back to those broad clinical features and talk about how they relate back to LBO. Sorry, this should be LBO, not SBO. So, oh, I didn't edit it out. My bad. I'm so sorry. So I forgot to edit out from the previous slide. Great. So LBOs less likely to present with vomiting, often present with more distension. They have a slower onset and constipation is more likely to happen. So just the opposite of what happens with an SBO. And here is just that. I would also like to quickly talk about radiographic changes that you see with each one. So I have a few images. If we go back here, so here we have an LBO. As you can see, what makes us think LBO versus SBO? Firstly, the positioning of the bowel loops. So as you can see, this is more peripheral. It's not as central. You can also see these lines, these haustra, which aren't going around the bowel. It's only going through half, right? And that is called a haustra. Versus a small bowel obstruction or small bowel itself, when visualized, tends to have these lines going across the entire length, and those are called the valvular conniventi. I absolutely butchered that. That was horrible. And a good thing we'll talk about is the 3-6-9 rule in a bit, and that will come on the next slide. So in terms of investigations, an ECG is good to rule out an ACS because it can present with atypical pain and abdominal pain, which is going to be very severe. And women typically have atypical anginal pain. In terms of bloods, an FB, UEC, LFT, and CMP. So let's go through what we're looking for in each one of these, because I think it's important. If you have any hemodynamic instability, you want to look for firstly the hemoglobin. If you suspect a bleed, you want to look at white cell counts if you suspect infections. With the UEC, we do this for a few reasons. Firstly, to check for electrolyte imbalances, which can happen with these obstructions. But then also, secondly, if we were to undergo any procedure, either surgery or imaging with contrast, you have to know what their kidney function is. And therefore, doing an eGFR is going to be useful for further interventions, even though it may not tell us a whole bunch about their acute diagnosis just yet. CMP is good because one of the major issues that we have with bowel obstruction is the leakage of fluid into the interstitial space of the bowel. And this can often lead to systemic dehydration and electrolyte abnormalities. And then lastly, an LFT, again, going back to firstly looking at the albumin, but then also if they have to undergo any procedure, we want to ensure that they don't have an acute inflammation of the liver going on. CRP is good because it tells us about acute inflammation. Lactate and VBG. So why are we doing a lactate? Well, lactate is a byproduct of anaerobic respiration. And therefore, if you suspect a bowel obstruction, your number one concern is ischemic or dead gut. And your lactate level, which can be seen on a venous blood gas, is a very good indicator of that. So systemic injury and ischemic damage, look at the lactate. And then also, if you suspect sepsis as a complication of that, please always consider septic screen. So this would include some of the things we've talked about already, plus blood cultures. In terms of imaging, we always want to start off with an abdominal X-ray. We would like to do both erect and supine studies, and we'll go through why in a second. We want to do a CT of the chest, abdo-pelvis, and this is the gold standard investigation. We can also do ultrasounds and contrast studies, and we'll talk about. So ultrasounds are particularly good for looking at things like intussusception, where you have a piece of bowel kind of telescoping into another one. It's mostly seen in pediatric populations, but it's still good to do. And also, if you want to rule out other causes of an acute abdomen, because remember, the patient is just going to have really, really bad abdo pain. So looking for things like appendicitis, your colies, looking for even pancreatic changes can sometimes show up on an ultrasound. Now, with contrast studies are good because they can often help visualize where exactly the obstruction is in the GI tract. Typically, we get them to swallow a radioactive isotope, and this shows up on an X-ray and can help visualize how far down the contrast is able to travel before it stops, and that would be the site of obstruction, right? And yep. However, so we usually do a barium enema swallow. However, if we suspect that the issue is that of a perforation, we don't want to give them a barium enema. We want to give them a water-soluble contrast instead. That's a very niche, tiny tidbit that's not really relevant, but just know that if you suspect a perforation, we don't want barium leaking into their peritoneum. So the first thing you want to do depends on how stable the patient is, right? If they are stable, do a CT chest abdo-pelvis, because this will give you the most information. If they're unstable, you don't have time to do a CT, and therefore an abdominal X-ray would be better. Things you would see on an X-ray include proximal bowel dilatation. So when you have an obstruction, the piece of bowel before that is going to enlarge. You can also have minimal air distal to the obstruction, a step ladder sign, or multiple air fluid levels, which is more commonly seen on an erect chest X-ray or abdo X-ray. And then you also want to look for signs of perforation and your pneumoperitoneum. So your football sign, your air under the diaphragm are all indications that there might have been a rupture and you now have air in the in the peritoneal space. And that's a really, really bad sign. You should know the 369 rule. And what this basically is that a transverse diameter greater than these numbers indicates dilation. And this is different for different parts of the bowel. So anything greater than 3 centimeters is dilated for small bowel, 6 for large, and 9 centimeters for the cecum. You can also have a whirl sign and a coffee bean sign in a volvulus and a target sign in intussusception. And going back to our two differences, so what I want you to appreciate firstly is how this is more peripheral, right? It's in the ends. This is more central. I want you to appreciate how the transverse diameter of this appears to be wider than this. And lastly, I want you to appreciate how these lines, as you can see here, are only going halfway. And these are the haustra of the large bowel versus the valvulae comitans of the small bowel that, as you can see, is going the entire length of the small bowel. So that's important as well. Now, going on to your management, you want to start off with your surgical prep. And hopefully by the end of this series, you are really, really familiar with this. And it really sounds professional when you know your good surgical prep. So instead of muffling around and not knowing what to get to, if you ever suspect an acute abdomen, you cannot go wrong with saying these things. So we want 2 large bore IV cannulas and start them on IV fluids. We want to insert a nasogastric tube left on free drainage. Why? Because with a blockage, a lot of the gastric content is going to come up, which is when they vomit. So we want to put a tube into their stomach, which drains any fluid that may come up. And we can often even start with evacuating the gastric contents first. They will be in pain, so give them good pain relief. And we want to also put them on antiemetics because they may be nauseous. We also want to start them on empirical antibiotics because we know that a big concern is perforation and sepsis. So we don't wait. We always start them on IV cafazolin, that's 2 grams, and IV metronidazole, that's 500 milligrams. You don't need to know the specific dosages, but if you know the names, I think that's really impressive. The definitive therapy depends on how severe the obstruction is and where the actual obstruction is. So surgical therapy, so you may be asked, well, we can obviously go conservative and surgical. When do you want to go surgical? You want to go surgical if there's a complicated obstruction. What I mean by complicated is if there's a volvulus, if there's vascular compromise, if there's dead gut, if there's signs of hemodynamic instability, if there is perforation, all of those, go for surgery. Or if there's a closed loop obstruction where there's an anatomical twisting of the bowel that is not going to be made better by simple medical therapy. You can also consider less complicated interventions for simpler obstructions, like endoscopic decompression or even a stool evacuation if the obstruction is in the large bowel or near the rectum. And then the final principle would be to treat the underlying cause. So if they have adhesions, well, in most cases, we don't do anything for the adhesions, but we can do something called adenolysis, or basically dissolving these adhesions. As we said, treat the hernias for large bowel obstructions. If there's a volvulus, correct that surgically. If there's a colorectal cancer, please look for it as well. And that is all we had for bowel obstructions. I hope that helped. Thank you all for coming in. And as always, please look after yourself and please look after your loved ones.